Very good afternoon to all. Sir, actually you nailed it. In a couple of slides that you showed, it brought out the crux of the entire session. And whatever you wanted, actually price point is a most sensitive issue as far as compliance is concerned, and you nailed it right there. So I'm going to be just elaborating a little bit on those lines itself. So biosimilars, my talk is big change on the horizon. So when I look at the horizon, I do not know how big the change would be, but I know for a fact there is going to be a change. And doctors can actually sit back and relax actually in this, because we are going to be spoiled for choice. Why? Because a lot of pharma houses are going to be fighting the game of clones or the game of biosimilars and warring with each other as to which is the cheapest, which is the most safe, which is the most effective in terms of cheap, safe, and effective. So it all began with the Rani, I would say, of all Zumabs, of all anti-VEGFs, drawing an analogy there, from the house Novartis, which is the parent molecule Lucentis, which is sold in India as Eccentrics. So we have the first warring house or the pharma house making the molecule Eccentrics from the house Novartis. Then we had the Razumab that was launched from the house Intas. We have Ranizurel from the house Reliance, and then we have Vizumab, last but not the least, from the house Cipla. And we have these primary warring houses fighting with each other, and each of them have a motto, so to say. If I have to draw an analogy from Game of Thrones, where I have taken this from, let's see what those sigils or mottos are. For Novartis, it would be made with Swiss precision, no doubt, but it is priced like the Swiss Rolex. So it's very unaffordable to the Indian masses. So the penetrance of this molecule is going to be lesser and lesser over time as other molecules become effective and cheaper, especially the biosimilars. So as far as Reliance is concerned, their motto I probably feel is we are reliably unreliable, but still we will do business if there is money. As far as Intas is concerned, we make it good, especially when we are the first. They were the first to come up with this biosimilar. But Cipla would go one step ahead probably and would say, we can make it good, but we catch up even better because we are way cheaper. So as far as the war between the houses is concerned, and may the best house win, the biggest advantage for us is they're all made in India. And as far as only 6 approved molecules of US and 35 approved molecules of European Union is concerned, Indian biosimilar market is far more liberal with 68 biosimilars that have been approved. So if you see the biosimilars of ranibizumab that are in the pipeline internationally, the principal amongst them being Formycon and BioEq, Phoenix, Coherus and Samsung, BioEpis, as well as Xlucane or Xbrain. This is from Sweden, some are from Germany, a few from US, and Samsung, as you know, from South Korea. All of them are probably in the preclinical or phase 1, phase 2, phase 3, and have not yet launched full-fledged in the market. So yes, we may fight amongst ourselves, but still it takes us, we should take pride in the fact that we are the ones to obtain the requisite approvals and launch biosimilars in a big way. So let's see, while each of them fight it out, which is the first aspect, which is the cheapest of them. As Dr. Lalit Verma clearly pointed out, if you see, let's not go with the MRPs, let us go with the procurement price to the surgeon. And it clearly stands out that as every successive biosimilar that was launched, it went cheaper and cheaper. And this competition is good, not only definitely for the doctors, but more so for the patients, because the compliance issue is easily met with and they can take more number of injections if they are able to afford it. So every presentation, how it begins with min financial interest, I'm not talking about myself, I'm talking about full financial interest, keeping the patients in mind primarily. Because as we know, we can do cataract one time or LASIK one time, but retinal injections we have to do time after time. Because no matter what you do to the disease, keep on giving injections, the disease have the habit of waking up from the dead and keeping on coming time after time. So as you see diabetics and what they propound as protocol S, it was initially thought that 3 sittings of laser PRP would suffice and the vision would still remain 6/6. But now what is propounded by way of protocol S is that you take monthly injections and the vision still remains 6/6, but there is a gross difference. You get here 6/6 at the cost of losing contrast and field of vision as against injections where you preserve them. So injection is definitely the way forward. And if the quintessential Mahaband test, it means to say that if the patient were your mother or your sister, would you actually go for PRP or would you go for injections, especially considering this criteria? I would go for injections provided I can match up compliance. And the only way to do that, let's say if you require 9 injections, let's say on an average 6 weekly basis in a year, as what the protocol S study says, if I were to take a cheaper molecule, it would cost me somewhere around 72,000 rupees a year. This is definitely more expensive than laser PRP 3 sittings, which would be something like 15 or 1,000, but it is much better than taking corresponding 9 injections of eccentrics. Each probably, I'm just considering the injection cost here, not even the surgeon cost or the cost of injection, would amount to 1,75,000 a year, which is way more than double compared to Cipla. So yes, if the compliance is ensured and the patients can afford, the motto should be keep calm and keep giving anti-VEGFs. It is way better in terms of outcome than giving laser. As far as AMD, the second principal indication is concerned, we now follow commonly what we call as a treat and extend regimen. As you saw from the early on regimen, which was fixed interval dosing, monthly intervals, as what the Anchor, Focus and Marina study showed, you had a good improvement of 10 to 12 letters. As against that, if you gave a 2 monthly or an average only 6 injections in a year, you actually lost letters. So the path was somewhere in between, which we call as a treat and extend regimen, wherein if you give injections on an average, if you count these injections, there would be 3 monthly, then 1, 2, 3, 4, 5, 6 more. That would amount to approximately, let's say, 9 injections a year, not as much as 12 injections, not as little as 6 injections. And if you were to substitute all those Lucentices with Vizumabs, it would amount to a cost again of around 72,000 a year, as against the exorbitant cost of Lucentis. Here, 4 injections of Lucentis would actually amount to 9.5 injections of Vizumabs. This I'm taking just the price of the injection, surgeon cost definitely being separate. So here in AMD as well, you keep calm and keep giving anti-VEGFs. So as far as the price is concerned, we have a clear winner here. Let's see the safety and efficacy aspect. Now, the efficacy of any biosimilar will depend on how matched it is compared to the parent molecule. So if you have a fingerprint match, yes, it will definitely be efficacious, but this process is a rigorous process because we are not manufacturing, or rather Cipla is not manufacturing, or any biosimilar company is not manufacturing something that is generic, which is just a chemical similar to the parent molecule. We are manufacturing this is a very simple molecule where you can easily make a generic medication. We are making something far more complex, which is a biological drug or a protein, so to say. It is like comparing a cycle to an aeroplane. So biosimilar, you have a protein. So if in a biosimilar, the definite criteria is that the primary structure of the protein has to be similar. It is similar to the parent molecule. And you have minor variations depending from batch to batch, as well as the place where it is actually made. There are variations in quaternary structure, configuration of sugar molecules, and additives. Let's see the first one, variations in quaternary structure. You know, the primary structure of protein is just a sequence of amino acids comparable to the alphabets in a word. Secondary structure would be similar to a word where the alphabets are put together. When words are put together into a sentence, it is very similar to the tertiary structure, and then go on to the paragraph. So if you see, the structure becomes more and more complex. So you are likely to have differences not only varying from batch to batch, but also between different biosimilars manufactured by different pharma houses. So apart from the variations in the quaternary structure, the additives that you actually add to make up the complete drug, or the configuration of the sugar molecules that you add to it, also make a difference. So based on these differences between biosimilars, we can have one of these 3 scenarios. The first is, let's say the original you have and the biosimilar, and the original definitely is better than the biosimilar. This scene is not acceptable because a molecule, though may be cheap, it may not be as efficacious or probably not as safe. So definitely not acceptable. The second scenario, where the original and the biosimilar, let's say, almost equivalent to each other, yes, this is acceptable, and this is what everyone is actually trying to achieve. All the biosimilar manufacturing companies are trying to match the parent molecule in terms of efficacy and safety. Let's look at the third scenario. You have the original or the parent molecule, and you have a biosimilar actually that turns out to be better than the original molecule. And this situation is definitely more than acceptable. And this is what the companies, now that they know how to make a biosimilar, they should try to achieve. So when I say better than biosimilar means bio better, it is a term now that is frequently used in the pharma circles, where you alter the pharmacokinetics and the tolerability of the molecule for a specific indication. You make it probably safer, and you make it longer lasting inside the eye. And people have been able to do, where a biosimilar of trastuzumab or obinutuzumab have acted better in cases of breast cancer and CLL. So why not in the eye? So when I say, when I am going to look back and gaze at the horizon, what is it telling for Cipla? Cipla should aim towards making bio better, or for that matter, any pharma house should aim towards making bio better as compared to a biosimilar. With this, I end my talk. Thank you all.
Thank you, Saumil, for putting this in a very, very simple way and easy to understand also. You see, we all understand that similar is similar, only similar can't be same, because you're not following the same E. coli or from where this is being processed. So, what are the challenges of making it bio better? You see, that is the biggest challenge. The three examples which you showed pictorially conveys everything. But you see, is it so simple that this can be made bio better easily?
It's definitely not simple, sir. I mean, it's not that simple, and that is the biggest challenge ahead. If they can do something, see, the price point is there. They are definitely going to do well based on the price point. But if they have better pharmacokinetics, I think they will go a long way, and probably they will have a better export value as well. And they can actually substitute for the parent molecule as well.
See, I know export value and all these things, but believe me, even I, Mohan, we are waiting for you. Yeah. See, I understand, because even Inta's biosimilar hasn't been able to, being exported to Africa or Nepal or SAARC countries. I have been struggling with that why can't even our neighboring countries use that? So somehow there's a issue. You see, you rightly pointed out that cost is not an issue. Saurabh, cost is not the only issue, because efficacy and safety is more important than, because I don't want to use a molecule which brings some side effects in my patient, brings out inflammation in my patient, or creates some issues and decreases my image also. You see, issue is that I am known for something, or Saurav or Mohan or Avnindra or Puneet, very happy to see you here. You see, we start using just to help the patient, with तुम्हारा cost कम हो जाएगा, but in effect you lose the patient and lose the entire family or his close contacts because something has resulted. Saurabh?
Well, I agree with you. They've given me 2 sample vials, Cipla. I have not used both of them. I'm waiting for neovascular glaucoma patients. NVG patients, I will use them first, because I'm very scared, exactly what you said. Efficacy, more important, the side effect part of it. I don't mean to, I have nothing against this. I did the same for Azimab also. So it's not that I love Avastin or anything. No, price is absolutely bang on, but I will use it to NVG patients, see for reaction and for my own thing, and I'll keep asking everybody, Saumil, everybody, use kya. That's all I'm going to ask for. Saumil, please go ahead.
Sir. Yeah, I'll come to you. People at center side are waiting that I will use first, and then other people will use.
Same here,
there is an apprehension, there's a fear. Yes, Saumil.
Sir, Dr. Saurav, I can identify with the fear that you have, and I've done a similar thing. I've actually used it in patients that are scheduled for surgery. Preoperatively, like how you give Avastin, in this case you give Vizumab, because even if the molecule is going to have certain toxicity, it's going to get washed off within 48 hours when you actually do a surgery. And when you go inside, you will know whether you're getting that angiofibrotic switch, even a little bit, as what you saw preoperatively, it means that it works a little bit. So I've used it in those patients.
I would like to add here, I would endorse what Lalit Verma says. I think the cost is a factor, but more important than that is the safety profile of any molecule. The safety profile is something which we have to keep in mind. I think the topmost in our mind. Okay, before we venture into new molecules like this. Even the efficacy comes second. The safety profile comes first, efficacy, then the cost.
First is safety. First is always safety. You see, Samuel, the example which you gave, I also was wanting that, but believe me, that is not a real world scenario. In a DME or ARMD, it's not 1 or 2 days of pre-surgical patient which you're trying to compare. That may not be similar. So it has to be a patient of SCAR patient or ARMD patient or a patient like NVG, where you see that patient ko chalo hafta do hafta dekh liya, nothing happens. Then you try and say vision of 3/60, never in one-eyed patient first. So that will give you confidence, and that will, you see, I'm sure, 100% sure that this will prove to be effective. Same happened with Razu story also. Neither any views? Or Dr. Rekha?
We need to have experience.
Yeah.
We need to have experience about first the safety and then the efficacy. Then it comes into the practice.
Absolutely.
Efficacy comes second, safety comes first.
That's what Mohan Rajan said. See, all of us agree, and that is the reason I advised, or in fact, I told Cipla people that let's design a common performa. Let Saumil, Saurav, Mohan, Avindra, Rekha, everybody use it, and let's share on a Zoom platform with what has been your experiences. Because once the fear also is shared, there are dar bhi share ho gaya, so then you become a share in the sense that you tend to use it more often.